Good afternoon, everybody. Welcome to the APDR National Virtual Noon Conference Lecture Series. My name is Dr. Harp Beatty. I chair the APDR Education Committee, and I am the Neuroradiology Fellowship Director at Boston Medical Center. And it is, again, with great pleasure, I bring you guys two amazing speakers today on abdominal imaging topics. We are so fortunate to have Dr. Webb and Dr. Fishman join us today for this noon conference. I just want to review a couple housekeeping items again to remind you all that the webinar is being recorded and the written questions and comments will also be recorded. If you have questions, please use the question and answer tool at the bottom, and the speakers will try to address those questions either after their talk or during the next person's talk. The chat tool will not be working. In addition, the lectures are being recorded and will be posted on the APDR YouTube site for, you can watch them after we post them. It's about a week turnaround for that. So without further ado, I would like to introduce our two speakers for today, Dr. Emily Webb, Professor of Radiology at the University of California, San Francisco, and Dr. Elliot Fishman, Professor of Radiology at Johns Hopkins. Dr. Webb will be speaking on CT of appendicitis and Dr. Fishman on CT evaluation of small bowel tumors. So without further ado, I'd like to bring Dr. Webb to ask her to share her screen.
Okay, see it?
Yep.
Okay, you can see it. Okay. Hi, thanks for joining us this morning, or at least here in California where I am. It is still morning. I guess it is noon where some of you are. My name is Emily Webb. I'm going to be talking about imaging of appendicitis today. And the thing about appendicitis is, you know, sometimes it's a really easy diagnosis to make. And I always think when I go to lecture about appendicitis that people are going to be like, why do I need to listen to a lecture about appendicitis? But the flip side to this is that when these cases are difficult, they can be really difficult. So I'm going to focus today a little bit more on some of these problem scenarios and give you some tips as to how I deal with them. So what we're going to cover briefly, a little bit about diagnosis, how to make this diagnosis, but then we're going to concentrate most on the potential pitfalls, where we as radiologists tend to make mistakes, and then I'm going to finish just with a few words on pregnancy. Okay, so diagnosis. This is pretty straightforward. When we want to make a diagnosis of appendicitis, we're just trying to figure out, number one, if appendicitis is present or not. And number two, is it complicated or not? Because obviously that can affect patient management. So let's start with these 2 points. Do we have appendicitis? So what is the best sign for appendicitis at CT? And really, it's actually just appendiceal enlargement. It is the most accurate sign, but accuracy is obviously going to depend on whatever we set our threshold at for defining enlargement, and this is like a little bit debatable. So there's obviously this number of 6 millimeters out there. If we set our threshold at 6 millimeters, that anything larger than 6 millimeters is abnormal, we're going to overcall appendicitis a lot of the time. But if we set it at something arbitrarily higher, I've said 12 millimeters here, that's sort of a random number, I just doubled it. But you know, if we set it at something higher like that, we're obviously going to miss cases. So enlargement, an important sign, but this number, this threshold is something critical that we're going to have to come back to. But I'm going to put that issue aside for a moment and talk a little bit about the other signs of appendicitis, because when some of these are present, you know, with a sort of big-ish appendix, often the diagnosis becomes a lot easier. So the first very well-known sign, periappendiceal fat stranding. So we see lots of inflammation surrounding this appendix. If the appendix is a little big, you see this, you know, you've got your slam dunk diagnosis of appendicitis. Another one, if you're using IV contrast, you can look for wall hyperenhancement. We can just sort of visually appreciate here that the appendiceal wall is brighter than the walls of adjacent bowel loops. It's hyperemic, a sign of inflammation and a sign of appendicitis. Wall thickening is, of course, another sign of inflammation and bowel wall edema that we can use to suggest a diagnosis of appendicitis. This is not my favorite of the so-called secondary signs of appendicitis because there's quite a range of normal of bowel wall thickness, and a thickness of the appendiceal wall up to 3 millimeters can be within the range of normal. So not always the best sign, but if you do see thickening, it adds additional evidence. And then this is one that I actually like a lot, and I don't feel like it gets quite enough attention most of the time, and that's the appearance of airless, low attenuation fluid filling the lumen of the appendix. Now, you'd think that, there's fluid in bowel, there's fluid in the, cecum a lot of the time, and therefore there might be fluid in the appendix. But it turns out that to see airless, so no bubbles of air, but just airless low attenuation fluid filling the lumen of the appendix very rarely happens in normal patients. You see it in less than 1% of normal patients. So usually this is a sign that something is up. This is one such case where this sign was helpful. This appendix was not that big. It was about 7 or 8 millimeters. Not a lot of inflammation around the appendix, but there was this airless low attenuation fluid filling the entire lumen. On the basis of that, we suggested that the patient might have early appendicitis, and that was subsequently proven at surgery. Now, this number that just popped up on the screen of 2.6 millimeters, that number is a number in the literature that refers not to the diameter of the appendix, but to the diameter of the fluid. So if you have this fluid in the lumen and you measure how thick it is, if it is greater than 2.6 millimeters, that has an especially high correlation with acute appendicitis. Now, I think the specific number is sort of ridiculous because who is measuring something to 0.6 millimeters? But this sort of general idea that the more fluid there is in the lumen, the more distended it is, the more likely it is to represent pathology, I think is important. You can sometimes have a little slip of fluid in the lumen, a millimeter or two, in normal patients. So here another example of this airless low attenuation fluid in the lumen. I want you to sort of note here that visually the fluid in the lumen actually kind of looks lower density than the fluid in adjacent bowel loops. That can be helpful in just finding the abnormal appendix sometimes. This sometimes is true that the fluid actually is lower density. If you put a Hounsfield unit on it, it's probably just due to different composition of the fluid due to appendiceal obstruction, higher mucus content, things like that. Sometimes it's actually not lower density. It's just a visual trick from the relative hyperemia of the wall. But in either case, something that can help you find that appendix. Here, an example of just a little bit of incidental fluid in the lumen. So this is one of those normal patients where there's just about a millimeter of fluid filling that lumen. Hopefully this is projecting well on your screens. Just a tiny trace bit. Probably don't need to get too excited about that. It's under that 2.6 millimeter threshold. Now this was a patient that came in for some completely other purpose. I don't remember what it was, cancer staging or something. And we saw this appendix filled with fluid, certainly more than 2.6 millimeters, but we didn't have any appropriate symptoms to go along with it. This turned out to be incidental. The patient did not have acute appendicitis. But in these rare circumstances where this occurs, I think that we need to either follow up with the patient, if the patient is still there on the scanner at the time you're reading the scan, just to find out if they're symptomatic, or if the patient is gone, to get in touch with the referring clinician just to make sure that somebody checks in with the patient and that they don't have symptoms that could suggest this diagnosis. It's just an unusual appearance in normal patients. Okay, so moving on from the diagnosis of appendicitis to the diagnosis of perforation. Sometimes perforation is obvious. These are probably the two best signs for looking for perforation, either free air, as we see in this first image, not a lot of free air. Sometimes the amount of free air in perforated appendicitis is pretty minimal, so look for those little dots. And in the second image, abscess. And I have these gold stars. These are our gold star signs. These are very specific for perforation. Now, there are a few more gold star signs that we see less frequently, but are very good signs of perforation when you see them. So wall necrosis, in this first image, we actually have pneumatosis in the wall of the appendix. It's gangrenous. And in the second image, you see a nice enhancement of the wall of the appendix and then a focal defect in the wall enhancement. Those are both also very specific signs for perforation. You just see them less often. So those get gold stars as well, although you're not likely to see them as commonly. Now, there are some other signs of perforation that I think are less well known, and rightfully so because they are less definitive, but they are things you want to note when you do see them. These are signs where the patient might have perforated, they might not have perforated, they just indicate severe inflammation. So in these instances, it's not the patient is perforated, don't bother to go to the OR, stick a drain in the abscess. These are cases where you're like, you know, this patient looks really sick, it's severe, go to the OR quickly and get that appendix out. So one sign to look for, ileus of adjacent bowel loop. So this patient had a clear appendicitis on a lower image, but this image I'm showing you here, we see these dilated adjacent small bowel loops suggesting severe inflammation, possible perforation. Periappendiceal fat stranding, so same idea. We know this is a good sign of appendiceal inflammation. I think of it as a continuum. If there's a little bit of stranding, you know, it's a good sign of appendicitis. But once you start seeing more and more stranding, like lots of stranding, lots of fluid, in this one image, this you know, really approaches phlegmon here. These are signs that the inflammation is very severe and the appendix may have perforated. And sort of the last in this category, cecal wall thickening. So you have an appendicitis and you actually see thickening of the adjacent cecal wall. It's a sign of severe inflammation. You want to consider whether this patient is perforated. They should probably take the patient to the OR quickly, not sort of wait 12 hours and do it in the morning. Okay, so that's how we make a diagnosis. Let's talk about pitfalls. And the way I see it, there are three relatively common pitfalls in making a diagnosis of appendicitis. The first is that you've got an appendix that's kind of big, but you don't have other obvious signs of inflammation. The second is when you can't find it. And the third is when you see evidence of right lower quadrant inflammation, but the appendix either looks pretty unremarkable or you can't find it, but there is right lower quadrant inflammation. So we're going to go through each of those scenarios one at a time, and we're going to start with enlargement without other signs of inflammation. So now I am forced to come back to that threshold issue of size, and where are we going to set our threshold for an enlarged appendix? So first, before we decide what's abnormal, let's talk about what is normal. So I refer to the 6 millimeter thing as the 6 millimeter myth. This just doesn't hold true, at least at CT. That number sort of emerged from the ultrasound literature where you're looking at the appendix with graded compression. But at CT, the diameter of the normal appendix is greater than 6 millimeters in about 40% of cases. So don't want to use that as a cutoff. Now we're of course referring to an outer wall to outer wall diameter. And that statistic of 40% of these being larger than 6 millimeters does not take into consideration what is in the lumen of the appendix. So whether there's stool or air or fluid or whatever, it's just all comers. Now, most of the time, what's in the lumen is going to sort of help you figure out whether you're looking at an abnormal appendix or not. And it's really only appendices that are sort of collapsed or uniformly dense looking where it's going to be potentially challenging to determine whether a biggish appendix is normal or abnormal. So what am I talking about? Here's an example of an appendix that's 1 centimeter, clearly over that 6 millimeter number, but you know, everyone is going to call this normal. It's the walls are imperceptibly thin. You can barely see them. There's no inflammatory changes at all. It's just a centimeter because there's a lot of air in the lumen. So a totally normal looking appendix. But here's one, also a centimeter, that might be a bit more confusing. If this patient were symptomatic and have right lower quadrant pain, this is kind of big, but we don't really have anything else to support it. What do we do in these cases, and how often does that happen? So most of the time, you're going to see visible luminal contents that are going to help you sort of sort out whether it's normal or not. It's actually about 75% of cases. About a quarter of cases, it's going to be bigger than 6 millimeters and have that sort of uniformly dense, in about a quarter of cases, it's going to have that more equivocal sort of isodense or collapsed appearance. And of those quarter, the number that are greater than 6 millimeters are about 6 to 7%. So if we used just a 6 millimeter cutoff rigidly in these sort of equivocal looking cases, we would overcall appendicitis probably 6 to 7% of the time. So that's not as bad as 40%, but we still don't want to overcall it 6 to 7% of the time. So what do we do? How do we approach it? What are the statistics here? So here's one such case. We've got a patient with right lower quadrant pain, came in for rule out appendicitis. We see a big appendix. This is about a centimeter. Don't see any obvious signs of inflammation. This is the algorithm that I use. Now, I want you to notice first on this less than 6 millimeter size, if you've got a big appendix, you don't see any signs of stranding or fluid or anything around it, and it's less than 6 millimeters in diameter, appendicitis in 0% of cases. So that's where that 6 millimeter number is useful, not as an upper threshold cutoff, but if it is smaller than 6 millimeters and it doesn't look like anything else is going on, you can be very certain that there is no appendicitis. Go to the opposite side of this little algorithm. If you've got an appendix that's greater than 9 millimeters, so essentially this is 1 centimeter or larger, don't see any clear evidence of inflammation, appendicitis in 50% of patients. So a 50-50 chance. Essentially that's an equivocal scan, but it's also like an easy statistic to quote. It's big, they're symptomatic, don't see any stranding or anything, 50-50 chance. In the middle, it's a bit ambiguous, a low chance of appendicitis. Excuse me while I take a sip of coffee, it's still early here. Okay, so in clinical practice, fortunately, I think most cases do show some evidence of inflammation. It's actually rare that you're going to have just a big appendix and nothing else on the scan to sort of help you with it. These secondary signs can sometimes be subtle, though, so we want to look carefully for them. So this is an appendix that's about a centimeter. So based on that algorithm I just showed you, if this patient were symptomatic and we didn't see anything else, this would be a 50-50 chance of appendicitis. But if we sort of scrutinize this carefully, we see just this little bit of hazy stranding right next to the appendix. Just seeing that little wisp of haze there probably pushes the likelihood of appendicitis from about 50% up to something much closer to 100%. So do look for these subtle signs of inflammation. Here, another subtle one. 2 appendices, one is normal, one is early acute appendicitis. These were both about a centimeter. If you notice in the normal case, it's pretty uniformly isodense. In the case of appendicitis, we actually see wall stratification. There's that hyperdense, hypodense, hyperdense layering target appearance of the bowel wall, indicates edema. That is appendicitis. Okay. So what about non-visualization? So, I mean, this of course happens all the time. Sometimes the thin reformats can help. Sometimes the coronal images can help, but sometimes you just can't find it. And this seems to always happen in the cases where we're asked to exclude appendicitis. You can see it in every other case. So 2 scenarios here. We're going to go down this side of the algorithm first, where we do not see the appendix and we do not see any evidence of inflammation in the right lower quadrant. And for a while, there was some discordance in the literature as to how likely appendicitis was in this circumstance. But then there was like a series of just, study after study in a row that all showed that if you do not see the appendix, but you do not see any inflammatory changes, the likelihood of appendicitis is about 2%. And I know just from looking at internal statistics at UCSF, it's similar. It's about 1.5%. So this is a good number. And it's also a reassuring number because if you go to these studies and look at that 2% of cases where appendicitis was missed, they were all cases that looked like this, where there was a lack of intra-abdominal fat, there were very crowded bowel loops in the pelvis, and when radiologists reviewed those cases in retrospect, they weren't at all surprised that they had missed an appendicitis because they were just difficult cases. So what that means is if you do have a patient that has a good amount of intra-abdominal fat, if you can see fat around the cecum and you still don't see the appendix and you still don't see any evidence of inflammation, the likelihood of appendicitis is even lower than 2%. So really, I mean, we miss it 2% of the time, even when we can see it clearly, we, don't always call it accurately. So you can really consider this a negative CT result and move on. And the surgeons are familiar with that statistic. Okay, so our last scenario is where we have right lower quadrant inflammation, but we either can't see the appendix or the appendix looks pretty unremarkable. And of course, I'm talking about right lower quadrant inflammation that's not attributable to some other etiology on the scan. So first we're gonna go down, or now we're gonna go down this other side of the algorithm where we don't see the appendix, but we do have right lower quadrant stranding. Totally different scenario here. So, about 40 to 50% of these patients will have appendicitis. So the inflammatory changes make all the difference. I often actually consider right lower quadrant inflammation with a non-visualized appendix appendicitis until proven otherwise. Now, the last little sort of subcategory here where we see a relatively normal appendix, but there is some inflammation. This doesn't come up that often. It's probably the least common pitfall. When it does, a minority of these patients will turn out to have appendicitis. It's about a quarter of them. So here is one example. Appendix looks, pretty benign, small, air in the lumen, but there's some fluid right around it. First thing you want to do is look for any other explanation for the inflammatory changes in fluid. And in this case, when we looked elsewhere, there was terminal ileal thickening inflammation. This was Crohn's disease, with just some fluid sort of pooling around the appendix. But another one that was a bit more difficult, nice normal looking appendix. It was less than 6 millimeters, but some stranding and fluid right around it. This patient was in a vegetative state, so there was no physical exam to go along with it. They were septic by labs. The CT was obtained. Was it appendicitis? Was it not? What we did in this case was rescan the patient sometime later. The fluid had resolved. Don't know what it was about, but this was not appendicitis. 75% of cases are not going to be appendicitis. Okay, so when do we tend to make mistakes as radiologists? There's a couple ways we can blow this diagnosis. We can either miss the appendicitis, our CT false negatives, or we can overcall it, our false positives. So let's talk first about our missed cases. Two scenarios here. One is just perceptual error. It's there, it's abnormal, and we just don't see it. But what people sometimes are concerned about is that there will be cases where we see the appendix and something tricks us or reassures us into thinking it's normal when it actually is appendicitis. And what people are always worried about is air in the lumen. So I'm going to talk about that in a moment. First, just a few words about perceptual error. It does happen. Does anyone see the appendix here? I like to sort of like pull people when they're in person. It's a little more difficult over Zoom, but I will reveal it right there. This tubular fluid-filled structure in the right adnexa. This was a missed appendicitis. And I have looked back at all of our cases of missed appendicitis over the years at UCSF, and I feel like virtually always, when we miss an appendicitis, it is this exact scenario where it is a young woman and the appendix is sitting in the right adnexa. And I think that we just have a little bit of a visual blind spot for sort of tubular or cystic looking things in that location because of the ovaries and parametrial vessels and so on and so forth. So in young women, acute abdominal pain cases, I always do one last look through that right parametrial area, even if appendicitis is not like the #1 thing that they are suspecting. It's just a good check. And then luminal air. So luminal air is sometimes assumed to exclude appendicitis. The idea being it means the appendix is not obstructed. Therefore, they don't have appendicitis. But it's not that simple. You can't use that finding like that. You actually can see air in acute appendicitis in a large number of cases, a surprising number of cases. It's about 30% of cases you will see luminal air. But most of the time where you have acute appendicitis and there is luminal air, these are actually pretty severe cases of appendicitis. It's probably why the air is there, is that they're starting to get a little bit necrotic. So usually these are not a diagnostic dilemma. If the appendix looks bad and there's air, it's appendicitis. If there's air in the lumen and the appendix looks, otherwise pretty good, it's probably not appendicitis. It's really rare to have an equivocal case. So here's an example. We've got a big appendix, lots of stranding around it. There's lots of air in the lumen, but that's not going to reassure you that this is, in fact, normal. We've looked at patterns of air in the appendix, to see if some were more benign patterns and some were more suggestive of inflammation. To some extent, if you have like a air fluid level, that's a little bit more associated with inflammation, sort of spotty air like an abscess, a little bit more associated with inflammation. But in general, the patterns weren't actually that helpful. The presence or absence of air is not that helpful. So I just generally recommend not using air as a consideration when making this diagnosis. And then lastly, I want to talk a little bit about false positive CT. And there's a couple possible scenarios here. One is there are some mimics. There are some other things that can look like appendicitis. There are also some patients who are treated for appendicitis. We call it, they go off to the OR. Nope, not appendicitis. So those are presumably just our overcalls. And then there's an interesting category of patients where treatment is deferred. So we call appendicitis at CT. The surgeons disagree. They do not have surgery. What happens in those cases? So first, let's address the mimics. So I'm going to mag up on the appendix here. So big appendix, looks kind of thick-walled. There's stranding right around it. Certainly looks like it could be appendicitis. But in this case, there was actually more inflammation centered sort of here, this is right anterior to the iliocecal junction. This actually turned out to be a case of cecal diverticulitis at surgery because the surgeons were so convinced it was appendicitis. Another case, big looking appendix, but really big, lots of fluid in the lumen, sort of beyond what I was showing you in those other cases. And then we have this very characteristic curvilinear calcification near the base. This is a great look for an appendiceal mucocele. Can sometimes mimic an acute appendicitis. This is sort of an interesting one. Appendix is big. We don't see any evidence of inflammation. This is a case of cystic fibrosis. We actually have a large population of adult cystic fibrosis patients here. And patients with cystic fibrosis can see bowel wall changes. You can get thickening of the wall of the right colon, and they also develop big fat appendices. So you never want to call appendicitis in a patient with cystic fibrosis just based on the size of the appendix. They absolutely have to show inflammatory changes. Otherwise, you're just going to overcall it all the time because they all get these big appendices. Here, a big appendix, isodense appearance, some inflammatory changes around it, but also notice we see lymphadenopathy in the adjacent mesentery. This was lymphoma involving the actual appendix. Another case of appendiceal neoplasm mimicking appendicitis, looks hyperemic, looks like there's fluid in the lumen. This was a mucinous adenoma of the appendix. And then this is a case that's sort of in that same genre, but a little bit different. Here the appendix looks big, don't really see anything else going on. And this was incidental enlargement in cancer. And what I mean by that is not cancer involving the appendix itself, but cancer somewhere else in the body, like lung cancer, breast cancer. Sometimes in patients with cancer, it's about 2% of cases, you'll see these sort of unusually large, juicy looking appendices. And we're not sure why this occurs, if it's some sort of like lymphoid hyperplasia, some appendiceal rebound following chemo, something like that, but something that we occasionally see incidentally in cancer patients. And then one last mimic I always like to talk about. So here, big looking appendix, fluid filled lumen. This is a patient, we saw this. It was one of those ones where sort of it came across the scanner unexpectedly. We followed up to make sure the patient didn't have signs of acute appendicitis. They did not. But what else is going on here? Probably better seen on the coronal. There is actually a cecal mass here. That's why the appendix looks like this. There is some obstruction and there is some fluid accumulated in the lumen because of an obstructing cecal mass. So certainly when you see this look in the appendix and it doesn't seem to fit clinically, do scrutinize the cecum as well. We did not notice this on the initial read of the scan. Fortunately, the patient happened to have screening colonoscopy like 3 weeks later and it was caught. Okay, so the next scenario, false positive CTs, where we actually make an overcall. So we call appendicitis at CT, they go to the OR, it's a negative appendectomy. And a negative appendectomy can mean a couple things. It either means the appendix is normal or it just didn't need to come out. You know, maybe it wasn't totally normal, but it was a medically unnecessary appendectomy. In other words, not appendicitis. The negative appendectomy rate at surgery is about 2 to 3%. That is if you consider scans where we suggest appendicitis and they go to the OR. Sometimes you'll see higher negative appendectomy rates reported in the surgical literature. That refers to any patient that go to the OR, you know, on the basis of suspected appendicitis, regardless of whether they had a CT and regardless of what we said at the CT. We could say that it's negative for appendicitis and they don't believe us and operate anyway. But if we call it positive, about 2 to 3% of the time we're apparently overcalling it. Here are two such examples. I want to look at this one first, labeled normal appendix. So this was a case where we called early appendicitis, went to the OR, it was normal. I think probably these are just little vessels in the mesentery and somebody mistook it for fat stranding, just an overcall, an overcall of appendicitis. But this other case, labeled periappendicitis. Periappendicitis is a pathologic entity where you see inflammation and fibrosis surrounding the appendix, but the appendix itself is not inflamed. But every time I see something that looks like this at CT, I'm going to call it appendicitis, and this is an area where I don't mind making the overcall. So sometimes overcalls are valid. We don't want to miss a case of appendicitis. And then lastly, the sort of interesting category where we call appendicitis at CT, the surgeons don't treat because it just doesn't fit clinically. The patient is too well, the signs are wrong. About 40% of these patients will return with appendicitis. And I don't mean that they'll come back the next day and the surgeons were just wrong. They will come back sometime, over the next year or so. The mean interval in this study was about 118 days. And they have an increased incidence of perforation upon return. And what we think is going on here is that these are just cases of chronic or recurrent appendicitis. So looks just like acute appendicitis at CT, that's what we call it, does not fit clinically because the patients don't actually have acute appendicitis. But in these cases, the appropriate thing to do is to do an interval appendectomy non-emergently and not just send the patient home to forget about them forever. So if you ever have this circumstance where you and the surgeons are disagreeing, please suggest a diagnosis of chronic or recurrent appendicitis. This was one such case. We called this acute appendicitis, big appendix, with obstructing it, stranding around it. I mean, this seems like a slam dunk. The surgeons were like, nope, patient's not sick, no white count, it's not happening, we're not going to the OR. They sent the patient home. Patient came back about a year later with a CT scan that looked almost identical, except now it was perforated with a little bit of free air and had their appendectomy at that time. Would have been better to just take it out as a presumed case of chronic appendicitis. And then just to finish with a few words about pregnancy, because this is always a problem when it comes up. Appendicitis is the most common general surgical emergency in pregnancy, affects about 0.1% of pregnancies. There is not an increased incidence in pregnancy. It's actually slightly lower compared to a non-pregnant age-matched population. It just seems like there's an increased incidence because it's such a pain. And the reason it's a pain is because we want to avoid the scenario where we're CTing these little fetuses. So that leaves us with a couple of options. We can either do ultrasound or we can do MR. Ultrasound, I always like to quote this study from 2010 where they looked at pregnant women with suspected appendicitis over 5 years. Ultrasound only had a 46% sensitivity. In the same series, CT had 100%. And not surprisingly, the sensitivity of ultrasound was inversely correlated to gestational age. So the more pregnant they were, the worse ultrasound performed. Also, of course, it is operator dependent. The other non-radiation alternative is MR, of course. This is a meta-analysis. This first grouping of data had non-diagnostic scans excluded, which probably isn't a real reflection of the world. The second grouping included non-diagnostic scans, but still great sensitivity and specificity, much better than ultrasound. And look at this negative predictive value. So in negative scans, we could be very confident that those patients did not have appendicitis. We just have like an MR abdominal pain protocol. So, the residents can just sort of order this and get this going. And then, we can look at the scans with them when they come up in the middle of the night, which they're always in the middle of the night. Just includes a lot of single shot Baspen echo or haste images in every plane, trying to get a good look at that appendix. We like to get a T1. And then if the patient can manage it, having a fat sat T2 is sometimes nice to, look for edema, but not critical if the patient is uncomfortable on the scanner. So pretty simple protocol. You, of course, do not want to give gadolinium in pregnancy. So here, a normal appendix at MR, just a little sort of air-filled cross-section there and the little squiggle there, looking very normal and small. Contrast that with appendicitis at MR. So in this T1 weighted image, we're seeing fat stranding in the adjacent fat, the big appendix here, and on the T2 weighted image, we see that it's distended fluid in the lumen, appendicitis at MR. Now, if for some reason you cannot find the appendix at MR, and sometimes it can be hard, you can at least use it to sort of figure out where the cecum is. And if you have to do a CT to help the patient, you can maybe limit the scope and, give the patient a little less radiation than you might have to otherwise. And we've also found that MR is great for coming up with alternative diagnoses when appendicitis is absent. These were all cases for rule-out appendicitis. In this case, the patient actually had C. difficile colitis, which we were able to suggest at MR. And this case, we were able to diagnose small bowel obstruction. So this has been like a successful technique, so much so that we're starting to do MR for appendicitis in non-pregnant patients. And obviously, the sort of target group there is kids, particularly older ones who can be still enough for the MR. Good data, even better than in pregnancy. Still able to make alternate diagnoses. And when the patients are not pregnant, you can, of course, give contrast. So my summary recommendations: forget 6 millimeters as a discriminatory value. If you are going to use it as a lower limits threshold. If it's lower than that, it is almost certainly normal. Be wary of calling appendicitis with no secondary signs. Remember, a 1 centimeter appendix with no other evidence of inflammation, it's just a 50-50 chance. It's a pretty equivocal scan, and they're going to have a good clinical story. Remember that sign of airless low attenuation fluid in the lumen. It frequently indicates early appendicitis. Remember that if you do not see the appendix, but there's no inflammatory changes, you've essentially excluded a diagnosis of appendicitis. Luminal air, probably shouldn't use it. And then consider a diagnosis of chronic or recurrent appendicitis when CT findings and clinical findings are discordant. And lastly, remember MR in the pregnant patient. So thank you very much.